Welcome to the final part of our deep dive into anesthesia. This time, we're going right to the edge. We're going to explore those rare, high-stakes moments that really define what this specialty is all about and the incredible, almost unbelievable preparation that goes into managing them.
It's absolutely true that modern anesthesia is safer than it has ever been in history. But that safety, it isn't built on just hoping that nothing will ever go wrong. It's actually built on the exact opposite idea, the assumption that things can and sometimes will go wrong. So today isn't about how to avoid a crisis. It's about being perfectly, impeccably prepared for one when it happens.
All right, our first crisis is the perfect example of this. It's a condition called malignant hyperthermia, or MH for short, and you can think of it like a hidden genetic fire, a rare inherited disorder that lies dormant until suddenly it's unlocked by very specific anesthetic drugs.
So what is actually happening here on a microscopic level? Well, for people who have this genetic trait, there are mutations in a gene called RYR1, and this gene controls a tiny calcium channel on their muscle cells. When they get a triggering anesthetic, these channels basically get jammed open, and the cell is just flooded with a tidal wave of calcium.
And what you're seeing here is how quickly this whole thing escalates into a complete cellular firestorm. That flood of calcium, it triggers this intense, sustained, rigid muscle contraction across the entire body. This kicks the body into a massive hypermetabolic state. The cells just start burning through energy and oxygen at a ridiculous rate. For the anesthesiologist in the room, the very first sign, the alarm bell, is a sudden, sharp spike in the patient's exhaled carbon dioxide on the monitor. That's followed by a racing heart and that telltale muscle rigidity. It is a true, life-threatening medical emergency.
And this is where the power of preparedness and innovation really shines. There is a specific antidote, a drug called dantrolene. It works by directly blocking that faulty calcium channel. But just look at this comparison. The older versions of the drug required someone to mix 36, that's 36, separate vials in the middle of this escalating crisis. It was slow. It was chaotic. The modern version, Ryanodex, concentrates that exact same life-saving dose into just 3 vials that can be mixed in seconds. When every single moment counts, that kind of speed is literally the difference between life and death.
So if MH is a crisis unlocked by your genes, our next one is purely about the drugs. It's called local anesthetic systemic toxicity, or LAST. And this is exactly what it sounds like. It's what happens when a drug that's supposed to stay local, in one spot, accidentally goes global and gets into the entire bloodstream in toxic amounts.
Now, unlike the explosive sudden onset of MH, LAS tends to follow a more predictable, escalating pattern. And here's the crucial part. The brain shows symptoms first. The patient might say they feel numbness around their mouth, or notice a metallic taste, or a loud ringing in their ears. This quickly escalates to seizures as the drug messes with the brain's inhibitory pathways. It's only after these brain signs that the heart begins to fail. This progression, while scary, gives the anesthesiologist a critical, even a very brief, window to jump in and act before the heart actually stops.
So how do you stop it? The answer is so clever. You use something called intravenous lipid emulsion. It's essentially a sterile bag of medical-grade fat. The theory behind it is called the lipid sink. See, the toxic local anesthetic drug is highly fat-soluble. So, by flooding the bloodstream with all these lipids, you create this huge new fatty compartment for the drug to bind to. It's like throwing a giant molecular sponge into the blood that just soaks up the poison, physically pulling it away from the heart and brain tissue and trapping it where it can't do any more harm. As a bonus, it also gives the poisoned heart muscle a direct shot of energy. Just brilliant. And you guessed it, just like with MH, there is a very clear step-by-step rescue plan. The American Society of Regional Anesthesia has laid out this aggressive protocol. You immediately stop the injection, you call for help in the rescue kit, you protect the patient's airway, you control the seizures, and you immediately start giving that lipid emulsion. It's designed to take a chaotic, terrifying event and turn it into a structured, manageable crisis. But, these dramatic rescue plans are really only half the story. The absolute best way to manage a crisis is to prevent it from ever happening in the first place. And this is where we see the constant, quiet evolution of anesthesia, using science and technology not just for dramatic rescues, but to refine everyday procedures and make them fundamentally safer from the get-go.
Let's talk about the spinal headache. It's a pretty common complication after spinal anesthesia, and it used to be a much bigger problem. The cause? It was the needle. The older Quincke needle had a sharp cutting tip that would literally slice through the fibers of the dura. That's the tough membrane around the spinal cord. It left a hole that could leak spinal fluid, causing a horrible headache.
But then came this simple, ingenious innovation, the Whittaker, or pencil point needle. Its tip is rounded, so it doesn't cut the fibers, it just gently separates them. Then when the needle is pulled out, the fibers just spring back together elastically, sealing the hole. Such a tiny change in design, but it dramatically, vastly reduced the risk of this really unpleasant complication.
Here's another fantastic example of that refinement. For shoulder surgery, the old gold standard for pain control was something called an interscalene block. It was great for pain, but because of where the medicine was injected, it had a nearly 100% chance of paralyzing the diaphragm on that side of the body. That's a huge risk for anyone with breathing problems. So what did they do? New techniques were developed that target the nerves further down the line, much closer to the shoulder itself. And the results are incredible. You get the same excellent pain relief, but you virtually eliminate that dangerous side effect of diaphragm paralysis. This is safety through precision. It's just smarter.
So when you take all this knowledge, all this training, all this preparation, it has a physical form. It's the standardized emergency drug tray, and it's ready and waiting in every single operating room.
This table really just brings it all home. For every crisis we've talked about, and even some we haven't, there is a specific, life-saving tool right there, immediately at hand. For that genetic fire of malignant hyperthermia, you've got dantrolene. For the global toxicity of LAST, you grab the intralipid. For a sudden catastrophic airway closure called laryngospasm, you have succinylcholine. And the key thing to realize is that this isn't just a random pile of drugs. It's a pre-planned, pre-thought-out arsenal where every single tool has a precise purpose for a specific catastrophe.
And that, right there, is the core belief, the ethos of modern anesthesiology. It's a field built on vigilance, on preparation, and on a deep, profound respect for how the human body works. Ultimate safety isn't about luck. It's not about hoping for the best. It's about having the knowledge, the tools, and the training to know exactly what to do when the worst happens. It's about always being ready for the edge.